Okay, the webinar is starting. I hope everyone can hear me okay. Ladies and gentlemen, my name is Steve Love, President and CEO of the Dallas-Fort Worth Hospital Council, and we want to thank you for joining us today for this educational webinar. It's hosted in coordination with Wello, Inc., an associate member of the Council. Wello was created to provide better ways to control disease by using the very latest technology. As the pioneer inventor of automated wireless temperature monitoring using sensors coupled with cloud-based technology, the team at Wello recognized the need for improved disease control and contagion management in healthcare. They continually strive to improve and leverage technology for the prevention of disease and spread of disease. Today's topic is ending epidemics. What a timely discussion during flu season and the headlines surrounding the new coronavirus, COVID-19. In fact, just a few minutes ago at a press conference, Nancy Messenger, a top official at the Centers for Disease Control and Prevention, announced to reporters that she expects to see the coronavirus COVID-19 spread. In fact, her exact words, it's not a question of if this will happen, it's when it will happen. So we have an expert speaker that can really talk about and empower healthcare providers and others to give very actionable information about high-risk situations. At the same time, protecting employees and patients for exposure to infections. We're delighted that we have as our speaker today epidemiologist and certified industrial hygienist, Dr. Mary Cohen. Dr. Cohen is chairman of the Frontline Healthcare Workers Safety Foundation and has served formally with the Centers for Disease Control and Prevention, that we commonly refer to as the CDC, and the World Health Organization. There's also going to be a special input and additional information by the president of Wello, Inc., Mr. Rick Heller. So we look forward to this presentation. We think it's going to be very informative, and certainly it could not be more timely. Ladies and gentlemen, it's my privilege to introduce Dr. Mary Cohen.
Thank you very much, Steve, and thanks to all of you for joining us this afternoon. We originally conceived of this webinar to be generally about epidemics and specifically about epidemic preparedness in hospitals. However, since the last 2 months, issues have been totally overtaken by the global problem of spread of COVID-19. We are going to instead focus specifically on this outbreak and this virus. Of course, here in the United States right now, we are still in the midst of our influenza epidemics, both type A and type B. They're actively circulating. Influenza, by the way, is the only contagious illness spread by casual contact that's in the top 20 causes of death in the United States. So this is a very serious problem. We're not by any means trying to minimize the importance. It's just that the newness and the need to take specific action because of COVID-19 that we kind of substitute that for our conversation. We've been taking daily counts, watching through the internet number of cases. Yesterday, there were less than 80,000. Today, there's more than 81,000 cases confirmed. It's confirmed in 32 different countries on 5 continents. So by any definition or stretch of the imagination, despite what terminology games are played by various organizations, this is a global pandemic. I want to address how new pathogens emerge, just generally, and this is the latest example. One way is that existing benign animal pathogens jump, that is, from close proximity that humans have with their animals Those pathogens then infect humans, which leads to human spread in immunologically naive populations, that is, people who have never been exposed. We call this zoonoses, which is the root of most of these emerging pathogens. But also sometimes existing benign animal pathogens can commingle and mutate with human viruses, human pathogens. The normal rate and process of mutation causes new strains of existing pathogens to emerge, as well as creating new pathogens. Take note that viruses can undergo 500,000 generations in the span of one human generation, which makes mutation a very active process. In the normal human biome, benign microbes also can become opportunistic infections in immunocompromised people. Then they can become antibiotic resistant organisms that are spread human to human. That's another way that new pathogens emerge. Coronavirus is named for what they look like under an electron micrograph. They have spikes on their surfaces. These are protein spikes that are the actual receptor sites, how they infect cells, connect and enter cells. So they're called the crown viruses. The family includes multiple respiratory and gastrointestinal illness viruses. Most of these are not severe. In fact, perhaps as many as 40% of what we call the common cold are actually caused by coronaviruses, as opposed to rhinoviruses or other families of viruses. However, some of these coronaviruses, including the COVID 2019 virus, are much more severe illnesses. We're also familiar with SARS, which broke out in 2013, and MERS, which broke out a few years ago. I want to emphasize, and probably the most important point I want to make today, is that this COVID-19 virus is the real deal. Let's take a look at comparison of case fatality rates for the viruses that we've just talked about. Influenza, which we're all familiar with, has a case fatality rate of 0.2%. COVID-19 already has shown itself to be at least an order of magnitude 10 times higher than that in case fatality rate. And since we don't really know all the cases, we're not totally confident of the reports coming out of China, this number may well go up. SARS, as deadly as it was 11% case fatality rate and up to 50% case fatality rate in some age groups. So that was a really nasty virus. And MERS, similarly, 30 to 40% case fatality rate. So these are, when these viruses get serious, they get serious. The course of disease with COVID-19 is the first phase being very similar to influenza. There's viral replication in the host. Patients may be asymptomatic, but they will have elevated temperature. That's in fact the leading indicator of infection to be. Phase 2 in a patient is an immune system hyperreactivity. We sometimes call this a cytokine storm. It does happen rarely also in influenza, but it's where the immune system gets so active because of the attack of the virus that it actually attacks healthy tissue in the lungs as well as the viral invaders. This can lead to a phase 3 disease where you have a honeycombing effect of lung tissue, it's pulmonary destruction, and then respiratory failure from those holes in the honeycomb actually filling with fluid. It's a very, very painful, very, very nasty disease progress. Now, this is really important, this next slide. How does COVID-19 spread? There's a lot we still don't know. We know for certain that it spreads by droplet nuclei and by aerosol transmission. We're probably all familiar with that in the healthcare world. Droplets are sneezes and coughs of virus contained inside the wet, soggy raisins of mucus that's sneezed or spit out. And then that gets into the mucous membranes of another person through the eyes, nose, mouth, etc., and causes infection transmission. Aerosol is an actual inhalation where the particles, viral particles, are on respirable size, tiny airborne floating around particles of water molecules or mucus or what have you, and they're inhaled past the nose and throat indirectly into the lungs. What's unusual about COVID-19 is we have confirmed in patient isolates both viral presence in patient stools as well as in blood samples. So this means we know for certain the virus is being shed through these routes. We don't yet have confirmation that actual infection is transmitted that way, but it's highly likely because the viruses, likely wouldn't be there if they weren't aiming to go infect somebody else. So this is really important. It's unusual for a coronavirus, or really any virus, to be infectious across pretty much all routes of transmission. That and the fact that there's a relatively long latency period, the time between infection and actually getting sick of 14 days, those combined may explain the really high communicability of the COVID-19 virus, why it's spreading so fast and to so many people. Now, in our healthcare world, of course, we know from the work we did preparing after anthrax for biological weapons events or some such, we know that the masks needed for healthcare workers are N95s. These are protective against the aerosol transmission as well as the droplet transmission. This is a picture of a slide. I think y'all are going to have available to you the slide so you can read these. Funniest part of this to me is a picture that if you draw a peace sign or flowers or some other way to decorate your mask, you've pretty much violated its certification as being protective. So that's contraindicated. Healthcare workers are, I'm getting a note. Oh, that's on the CDC website. So that's easy to get if you want to make a poster of it or look at it in detail. Healthcare workers also play a critical role as an information resource in our communities in an outbreak situation. That's a very important role that we play. So an issue that always comes up is how effective are masks? And people in the public, of course, are used to seeing pictures, mostly from China and Asia, of whole crowds of people wearing various kinds of surgical masks or homemade versions from all kinds of materials, for a mask. So it's important to be able to answer questions for people about when they should really be using a mask, because those that people are wearing around in public like that aren't really effective other than protecting them from infecting somebody else. This next graphic is from the World Health Organization. I think it's worth going through these points, that healthy people really only need to wear a mask when they're taking care of a person who is suspected to be infected. They can wear a mask if they themselves are coughing or sneezing to protect other people from catching infection from them. That masks are only effective as an epidemic prevention tool when used in combination with frequent hand cleaning. Of course, soap and water is the gold standard, but even some kind of gel-based hand rub could be used as well when soap and water is not available. And only wear a mask if you really know how to use it and dispose of it properly. You can't reuse them over and over again, and they do get soggy from excellent and whatnot. So you have to be able to know how to change them and when to change them, et cetera. Right now, in this stage of the COVID-19 epidemic, hospitals need to take action. You need to assure that you have adequate stocks of PPE and worker training in how to use the PPE. It's time to dust off the drills that we did back in anthrax and Ebola preparedness plans. Make sure we're ready for patients to come in who will be confirmed later to have COVID-19. We need to review and revise our HR policies to accommodate workers needing to take a 14-day required quarantine period. This usually can be isolation at home, so long as they're taking oral temperature twice a day and reporting it into some central employee health station. Imagine that one patient and driver comes into your ER and then 2 or 3 days later tests positive for COVID-19. You then have to backtrack, look back, and take everybody that was exposed to that patient and put them on a mandatory 14-day quarantine. So how's that going to affect your staffing, et cetera, et cetera. Screening is a necessity in this time. Ought to be able to screen temperatures for all of those people coming into the hospital. That's not just patients and their drivers, but visitors, vendors, et cetera. And as Steve pointed out, just today, just actually a couple hours ago, Dr. Messonnier at CDC said very specifically that she said Americans have to brace themselves for an outbreak. I think we can look or should look at the history of other coronavirus outbreaks. So I want to invite now Rick Heller to come on and talk about some of that history.
Thank you much, Dr. Cohen. My name is Rick Heller with Wello Incorporated. We make a device that is self-service and non-touch and measures temperature for looking for elevated temperature, which we call fever. When you really consider coronavirus, most people have heard of SARS back in 2003. That's 17 years ago. Part of the irony of this webinar is that we're talking about ending epidemics. And SARS 2003 is a wonderful example of extincting, if I can use that word, a coronavirus that they called SARS. And it took about 6 months, and it was gone, pronounced never to return in July, and has since never returned. It's a cousin to the current coronavirus. One of the fastest hospitals to end this breakout was, and I won't even try to pronounce it, but it's a famous hospital, TTSH, the main hospital in Singapore. And what they did in Singapore is that they, for people who are non-patients, that would be any visitor, that would be any companion or healthcare worker, they took their temperatures 2 and in some cases 3 times a day. And from that, they created a screening procedure that could find people who were fevered. And with those fevered people, they would determine whether in fact they had SARS symptoms. There are obviously further symptoms for which you could get a closer to positive ID or actually a diagnosis that says that's not SARS. And so for those that were not SARS, they were sent home immediately because they tested fevered. And for those that were, they were admitted into the hospital. And it turned out a good number of all the SARS infected people in Singapore came through that hospital. And again, not as patients, but as companions, visitors, and healthcare workers. This moved on to many different places, not the least of which was Sunnybrook in Toronto, California, where they would screen anybody as they came in, as this practice became more and more valuable, or it was seen to be more and more valuable. Prince of Wales Hospital was an interesting hospital where there was a lot of outbreak, and the outbreak again was not necessarily vectored from patients. So the irony of this ending of this epidemic we were going to talk about is obviously in contrast to this new emerging so-called epidemic from Wuhan, China. We're calling nCoV-19. And while we might say that's starting, it happens to be coming up at about the same exact time as SARS came up. And it's likely to be a seasonal thing. It's likely to have come about slightly different than what the president says, which is he says basically it's going to be warming up and therefore it's going to turn down. While we agree with that, we believe that that is more a matter of humidity, winter being the very driest time of the year more than summer. So one of the personal takeaways from this is to make sure we hydrate. And at Prince of Wales Hospital, there was 2 or 3 outbreaks. You know, Hong Kong, you know that it's subtropical, it's a beautiful place, very humid. And you'll know that the couple of days where these outbreaks occurred with this, it was a coronavirus, SARS, and it had about a 5 to 7 day incubation period, that these were balmy days, these were beautiful days. But it happened, if you look at their humidity outside, and I don't mean relative humidity, but more or less dew point or absolute humidity, it was very dry. And that dryness is vectored into the building. So into the building comes sick people, and obviously they're isolated in their rooms if you're a patient. But if you're a healthcare worker and you're beginning to incubate this because you've been around, you've been in contact with these people, then you're going to have a potential outbreak in 5 to 7 days if you're susceptible. So this happened in Prince of Wales. There were 100 plus cases, and about a third of them ended in death, where altogether SARS is about 20%. So now you may have heard of MERS. It's a little less well known. It seems to have emerged in the past 5 or more years. It seems to be carried by animals in a tradition that we're not really sure of, but a tradition in the Arab Peninsula, Saudi Arabian Peninsula. One case made it from Saudi Arabia, just to give you an example of how exposed hospitals are to these things. One Korean gentleman went from Saudi Arabia to Korea, went through screening process. And within 2 months, that single person who incubated came up with several hospitals, 186 confirmed cases, 36 deaths. MERS is a coronavirus, as I said. In 2015, we seem to have it under control somewhat. We can't say it's gone the way of SARS. We think that may be because of this tradition that animals and people have with respect to an annual event. So we see now, obviously, COVID-19, and we know so little about it as compared to everything else. And we hope that it goes, if not the way of SARS, the way of MERS, where it begins to get some control. On the next slide is really the heart of how these things operate. These are epidemics. Each one of those little bubbles is a person and happens to have a name associated with them. This, I believe, was in Singapore. Every single one of those circles you see, which is all of 5, led to the suffering and the sickness of each of the person in that tree. So to have stopped any one of these people in those 5 circles would have been to stop any of the other ones from getting sick, presumably. The thing about each one of those circles, they're given a name, and it's sort of an arbitrary name called super spreaders. And we hear this a lot in the media. If you look back on SARS, you'll see super spreaders were talked about a lot. You'll see silent spreaders. This is the phantom, the idea that a person walking around who's well, could spread it to dozens of people, hundreds of people. And so, so the idea is to arrest each one of those and then ask the question, what is a super spreader? So as it turns out, and looking at all these super spreaders were all symptomatic. They could have been events. In these cases, they were all individuals that were in places where there were many people. Converse to the people at the ends of these who just went home, went to sleep, took care of themselves, and either checked back into the hospital or suffered at home until they recovered. So once again, the idea is that a super spreader is symptomatic. So we go to ask the question, who is contagious? Dr. Cohen teaches us very clearly that fever is the leading indicator of infection. In fact, any case write-up or any diagnosis is really going to be started with, do you have a fever? And so as a company that measures elevated body temperature without touch and simply without touch and self-service to where nobody is going to be infected from us measuring ourselves, we think that this is the sine qua non, without which you would not be into any other interesting part of a diagnosis or seeing a clinician. So fever comes first. Then we go to look at, this comes from a company named Welch Allen. So they make a hospital grade thermometer, many of you are familiar with. It measures different types of sites, in particular the oral site. So we put it into our mouth, and it's called sublingual. So it goes back there where it kind of hurts a little bit, and you really have to get it back in there. And you find out your temperature, and your temperature is about a half a degree to 3/4 of a degree lower than your actual core temperature. So there's some confusion that goes on that we'll talk about in just a moment. But the thing that's most interesting here is that little circle is when you look at the intersection of oral to greater than 65 years old, you'll see that the high is 98.5 degrees Fahrenheit. Again, this is measured orally. That number is very important because 98.6 is that thing that we all think of as normal body temperature. If you're reading the Wall Street Journal or Forbes magazine or even Scientific American, there's in the past 2 months and before even coronavirus, this nCoV-19 came out, everyone's talking about how evolution has changed body temperature to a much lower number. Well, all of our database, which is about 1 million scans or more, show that average body temperature is 97.8 degrees Fahrenheit. A little bit of a surprise for us. We weren't sure what to make of it till we went back over the more recent literature and found this to be true. But when you get older, you get colder. And getting colder just means your average body temperature. And that lowers, if you take a 1.5 degree Fahrenheit, which is sort of considered to be the measure of out of range from your average body temperature, you'll see that at 65 years old, 98.6 is in fact something that might be diagnosed as fever, and it's certainly something you should be concerned about. And as an individual, call your doctor. So we go to the next point, which is the question of an asymptomatic person. So we have this world where if you Google fever, you'll see consistently 100.4 CDC, University of Michigan, Mayo Clinic. You'll see these venerable institutions talking about fever. And what they're really talking about, we think, and we feel strongly, is that they're talking to the person. Like, don't worry, this is not an issue, take care of yourself. But if it gets to be 100.4 or greater, you might be in some trouble. You need to come in for a diagnosis. So there's this concept of asymptomatic spreading. If you have a super spreader who you cannot detect under any kind of surveillance, can spread to 100 people, I mean, all is lost. As far as ending an epidemic, there's not much that we're going to be able to do in science or in medicine. And we don't see this to be the case. And we have a good number of references of physicians who point out infectious disease that as you get this epidemic in your body, that is what fuels a fever. And they are completely, if not very connected. And that this fever is an indication of an abundance of virus. And then you do what's called shedding that virus. So the question comes up as to what temperature do we start to get symptoms? And so there's this wonderful study where they actually measured the exhalation of the amount of virus that was in the exhale based on a function of temperature. So these three little graphs that you see, one is a combined symptoms list. The very bottom one is your temperature going up. It's in degrees centigrade, but it's basically going up to 99.5 degrees as these what are called viral titers, which is just a measure of how much virus load you have in your exhale. And so consequently, this is showing you that temperature is highly connected to the amount of virus you give off. You'll also notice that towards the end, it begins to trail off, as does your temperature, as does your symptom list. So it's hard to say you get less contagious, but it really is much less virus as the recovery period gets nearer. If you go to the next one, this is data that we've collected, and this happened in the Mississippi Delta during flu season in a given year. And that was a place where sick people went. And I mean, it was an ambulance area that was 100 feet away. People who had contusions or broken bones, they didn't go there. The only people that went there were sick people. And what we saw was a complete shifting of that little line that comes down, this being what's called a histogram, which is the number of cases at a given temperature. And you can see that these people are on the verge as the line slopes down. And then you see these bumps all the way up to about 100, is that about 103, 104 degrees. And these are a certain number of patients that they're seeing out of some 700 or so patients. And what this illustrates is that if you just select 100.4 in this, in these self-described, hey, doctor, I'm sick, I need to come in, and it turns out, in fact, they do have elevated body temperature, you would be catching 7 people out of 700. But if you went down to 99.5, you would probably triple that. If you went down to 99.1, and we have reason to say that that has at least some confidence that there is, that they are in fact febrile, in fact infected, and then you'd be looking at 110. And what happens in most measurements, particularly thermograms that they do at the airports in Hong Kong, they have to set them very high because the thermograms, the thermography, the infrared cameras are fairly inaccurate, and that's not to put them down. It just happens to be the physics of the way they actually work. And they're plus or minus 2 degrees C, some a little better than others, and some calibrated, but still they have to set them high enough so that they don't catch otherwise what they call false positives. That would be somebody who really wasn't sick, and they have to stop them and do a clinical write-up. So that really is going back to the screening tools that we use today. In handheld thermometers, you'll see these pictures of people in the bunny suits or hazmat suits, and they're pointing this, it looks a little ominous, and there are a number of people in line, and they're pointing these guns at people's foreheads, and they're obviously just trying to pick up the temperature of these people. And they're looking for 100.4, and we're making an appeal at this point to the scientific community, and we're doing it through some very formal channels to just get down to the World Health Organization's standards of 99.5 that they've applied to many epidemics, and they've actually taken credit for stopping the spread of a given epidemic. So surveillance, while it's very important, it's also important that we, in a sense, raise our standards by lowering the definition of fever. And we can show you from over 1 million scans that lowering fever down to 99.1 will give you no more inconvenience to any particular traveler, given a couple of criteria that we have, than it would at 100.4. In fact, what you'll get is you'll get likely more cases of people who are contagious. So once again, to be somewhat promotional, as I tend to be with respect to Wello Station X, we are able to, this is just a walk-up, a device you walk up to, it talks to you and gives you your temperature within its degree of accuracy. It is FDA Class 2 medical device, and you can see on the next page that it's as simple as, 1, 2, 3. It's a 2 or 3 second process. We get pretty good at it here in our office. We have quite a few, and it takes about a second or two. So we go right up to it, we align, we see a picture of ourselves and a mirrored image, and we make sure that our bangs are out of the way, our hats are off, our eyeglasses are taken off. And then we identify with a picture of ourselves and a sticker, and we put it on. And that is, our face, our authentic number, our date that we took it, and a little I'm okay. Now, if you do not pass to what the setting is for the hospital that uses this, or various different places we'll talk about, then you don't get a sticker. And so the question is for anybody walking around, are they in fact, have they in fact gone past the machine and certainly past that, that surveillance? So we are in healthcare settings where we might be visiting, we certainly might be a healthcare worker, but at the other side are immunocompromised people, and we all have a fairly good idea of that, either for ourselves or for loved ones that have been through this. you know, the neonatal ICUs, various different ICUs. These are people in wound management and post-operative where they have open, you know, they're open to and thereby susceptible to anything that might be airborne or droplet borne. Bone marrow transplant, part of the therapy is to take your immune system and virtually turn it off to the first approximation, and those people can recover with a very high degree of probability, and they would even call it cured. But during that phase, 6 weeks, 10 weeks, 12 weeks, depending on how that course of treatment goes, they have no immune system. So a person who walks in there susceptible or sick is putting a lot of people at risk. Pediatric units, emergency departments, chemotherapy, and we can go on from there. What we have is other settings too that we've invited to this webinar. We have manufacturers, worldwide manufacturers, and they're very concerned. Now we're talking about COVID-19. Before we were talking about flu. Flu still outnumbers COVID-19 by significant amounts. In fact, you know, the death toll from influenza right now, depending on who you talk to, the counts are upwards in 25,000, 30,000 dead just in the United States alone, and it is a pandemic. Jails and prisons are areas that are very crowded, close quarters, and before an inmate comes in, they want to be sure that they have none. And we have this in counties all around the DFW area. We have child care schools out in Northern California. In other places, we have very unique systems where there's a child care and a senior care in the same place, and they have the problem on both sides of that. Places of work, I mean, we all know what goes on at work. You know, somebody comes in hacking and coughing, and just count to 2 or 3 days, and God forbid it's flu, somebody else gets it, 2 people, 3 people, who knows what. And then, of course, screening now has become very important at borders. So the most important thing that we feel for all this to end epidemics, and we saw this in SARS 2003 in Singapore, they were the first to end it by taking temperatures 3 times a day of people, that we enforce the protective masks, particularly for the sick people. And that if you do have a fever, we've seen some hospitals between 99.1 and 99.5, which is today considered asymptomatic, that they do wear a protective mask. You do get reductions of 90 to 99% less viral shed just from your exhale. We begin to now screen non-patients, and you'll see this in children's hospitals. They'll give you a survey, and your survey is, have you been sick in the past 30 days? Have you had a fever in the past 24 hours? During Ebola, it was, have you been to West Africa in the past 30 days? These kinds of things. But we just say, you know, go to the Wello station and just see if you are harboring anything at the moment. And as we begin to do this, we cinch down with the temperature going lower, which is stricter, and we take appropriate steps. The first thing to do after somebody scans in, which is not all that often, and they cannot get a sticker, is that we go to other kinds of thermometry, which are certainly available at hospitals, even a lot of businesses we see with a second type of thermometer. And ultimately, what we think is going to be happening, even with then COVID, with 19, and with all these others, is that the hospitals, unlike the offices where we're kind of spreading it around, and schools, the hospitals are going to be the last stage of this. And we saw that in Wuhan, almost 50% of the infections that Wuhan saw were all coming and had all been at the hospital, whether they be healthcare workers or visitors, about a week before that. So we know that the hospitals, if they're not ground zero for getting this, they're really the last step that can actually put these epidemics down. And failing that, they actually can do the very opposite. And that's one of the great ironies of these epidemics and the role of healthcare in them. And I want to thank you for listening to me. I want to pass on to Dr. Cohen.
Thank you very much, Rick. Before we get into question and answers, we wanted to make sure we left adequate time for your questions. As an epidemiologist, I'm usually called upon to look around corners or look into the future, take a look data at what has happened and make predictions of what is going to happen. So Rick and I have been talking over several days, arguing over several days of what we might best expect from presentation of COVID-19 thus far. On the short run, I think that there's some good news. Vaccine development for those who are infected or to keep people from getting infected is on a fast track development. We already are doing testing of other existing coronavirus vaccines to see how active they might be against COVID-19. But also a study was published just last week at the University of Texas down in Austin on an NIH grant, where they have already isolated the specific spike or protein on the COVID-19 surface that is responsible for entry into a cell, a way to infect a cell. So that rapidly speeds up the ability to develop a vaccine and possibly even an antiviral therapy to the COVID-19 virus. By fast track, that still means, though, it's a year away. So what does that mean for us? Well, as Rick mentioned, COVID-19 now is pretty much, the genie's come out of the bottle. It's very likely to become seasonal and worldwide, just like, say, H1N1 influenza. I don't see us being able to extinct this one as we were able to do with SARS, as Rick pointed out. So we need to begin to prepare or be ready. Let's live through this first season and try to not be overwhelmed by this virus, and then prepare for it as a pretty normal part of life in the future. Now, on the other hand, what's not such good news is that the pharmaceutical industry has largely abandoned infectious disease R&D. There's a whole lot about the business model for vaccines and antivirals that just doesn't make sense to them as compared with developing treatments for chronic diseases such as cancer or diabetes. So outside of government research, primarily sponsored by the NIH, we don't have a lot of this kind of development happening. That's why personally, I think it was very good news that we had the announcement just today from the White House that they are putting in request of Congress for a very large supplemental appropriation specifically to do this kind of R&D for coronavirus. Whenever we do that, the successes spill over into other infectious disease problems. For example, everything we've been able to do in quickly identifying COVID-19 over the last 6 weeks was spawned by the space program of virology science that was done back in the 80s for HIV. So the development, all the technology, techniques, and equipment there have paid off for new viruses happening now in the 21st century. I'm going to let Rick give you some of his even more optimistic viewpoints for the long term on our fight against coronavirus 19.
Well, I think this may be more hope, but that there will be some turn down. Right now, there's going to be what we suspect from our models. We model this based on moisture and humidity. There's going to be a flood of further cases, particularly in Wuhan. There'll be a bit more outbreaks as you're seeing, countries not only being added to the list, but case counts going up. As you see all that, we're actually going into what the president called a warming period and said that it would actually subside. And we do see that consistently with influenza, where it's attributed to what's called herd immunity, which means pretty much all the people that could get it have gotten it in simple terms. But also that the moisture that is in your building is actually friction, if you will, to the spread of disease. And conversely, in very cold areas, what happens is that we entrain or we move in the outside air in commercial buildings to the inside and then exhaust the inside to the outside. And so we're the same moisture. Whether you call it relative humidity or not doesn't matter because it's not. But what it is it's the same amount of moisture. When it's very dry, you will spread more virus and to more people. So the way to avoid that is to keep sick people, that is fevered people out. And the way to detect fevered people is to, in a sense, lower your standard or actually increase your amount of surveillance by lowering the temperature that we call fever. And so with that, I think ending an epidemic is a possibility. I really want to emphasize that with these kinds of things, and that we're paying attention worldwide right now. Thank you very much for that, Dr. Cohen.
Thank y'all for that very good presentation. I think we're going to go to Q&A now, if that's okay. And we've already got 2 questions in the queue. The first question, at a press conference earlier today, President Trump said a vaccine is very close. And then afterwards, the White House released a statement saying he was referring to Ebola, not Corona. So my question to you is there a process to produce a vaccine for the coronavirus? And if so, do you have any time frame that would take?
Yes, I'll take that one. First of all, the correction that the White House made refers to FDA actually approving and licensing an Ebola vaccine in December. And that there's already been 3 different vaccine trials in West Africa after the Ebola outbreak of 14-15. One of those has proven successful and is licensed now for production. So he was correct on that one. The coronavirus vaccine, the process is the same regardless of the kind of virus. It's the same for influenza or anything else. And historically, it goes back to those of you who will remember 1975 when we had a swine flu outbreak or a predicted outbreak in the Gerald Ford administration. And we had a massive national deployment of vaccinating everybody against this predicted swine flu virus. And President Ford, with great celebration, rolled up his sleeve on national TV and took the shot to show everybody it was okay to take. And then it turned out that the epidemic never happened, but we did have an awful lot of people who had serious debilitating side effects from the vaccine, including paralysis. And as a result of that, vaccine manufacturers got sued and went out of business. And ever since then, vaccine development has pretty much been by the US government, run by a part of the National Institutes of Health called the National Vaccine R&D Center. So that's the process. But they've already given a number of grants out to university research laboratories primarily, working on, as I mentioned, testing existing viruses to see, testing existing vaccines to see how reactive they are against COVID-19. So that's ongoing and likely will produce some kind of effect. They will have some kind of effect. We just don't know if it'll be enough to actually manufacture and deploy the vaccine. But as I mentioned, a very important study published just last week out of the University of Texas, Austin, is extremely promising, and I will predict we'll have an approved vaccine for COVID-19 by the time we get to next winter, the next seasonal outbreak expectation for this virus.
Thank you. Rick, I think this next question may be for you. Can these be deployed? I'm assuming they're talking about, what you've developed. Can these be deployed in a free, frequent setting, somewhat like in a drugstore or grocery store where there are blood pressure monitoring stations?
Indeed, we think that's an excellent idea. We have had conversations with retailers. We haven't gone as far with them as we've gone with hospitals and others, but this would be an ideal place for that. And for pharmacists to even help people in trying to give them ideas and suggestions for how to treat it, or in most cases, how not to treat it.
Got it. The other question that we've received is, what is the current recommendation or your latest thinking for alert temperature when you're doing temperature screening?
We have a default number of 99.5. It is strictly up to the customer where they wish to set it and what they wish to do with a person who exceeds their limit.
Another question.
In our office, we use 99.1 degree Fahrenheit. And, it happens that towards the end of the day, and I'm telling you, it's like 4 to 6 o'clock, it's called the diurnal cycle, where at that time we can come up about 0.2 or 0.3 degrees. So somebody is at 98.7, which, young person, all of a sudden they get to 99.1, they might trip that. We might ask them to wear a mask. So we don't get very strict at the lower numbers, but we pay attention.
Steve, let me weigh in on that also from an epidemiologic perspective. And it goes to the slide that Rick described, where we had that from the study that we did in the Mississippi Delta a few years back. What we have to do in screening is try to miss or minimize any false negatives. False positives are okay. That means you have a slight inconvenience of someone who's not really sick, who has to undergo some sort of assessment, Q&A or whatnot. But as seen in that super spreader slide of the neural networks and how one person can cause so many infections, and an entire SARS outbreak was really caused by 5 people after contact tracing at the end. You really want to get as sensitive as you can politically, if you will, stand, as you can get away with in a given audience, to try to make sure that you don't have any false negatives.
Thank you. A couple of comments and questions we also received. Dr. Cohen, one of the people on the webinar said they heard you reference a 2013 SARS, and they said, did we miss something on that? Could you expand a little more on the 2013 SARS that you referred to? That's question one. And then two, how effective, in y'all's expert opinion, is it to monitor asymptomatic carriers?
Well, I'll take the first one and let Rick have the second one. What I meant was 2003. If I said 2013, then I literally got ahead of myself.
Okay, so you were referring to 2003.
Yes, and as a matter of fact, in March of 2003, I was with WHO. I was in Geneva as that outbreak was emerging and developing, and it was kind of interesting. It was a little bit like a space launch. The Director General had a conference room with TVs all around the room on the wall, and every day at 1:30 Geneva time was a worldwide conference call, and literally 100 or more ministries of health were on the call to provide any information that was new from just the last 24 hours. And that's how we really got a handle on SARS so quickly. But that was 2003.
In answer to the question about asymptomatic spread, is one thing that we can be pretty fairly sure of is that the idea of super spreader by an asymptomatic person is very unlikely. And then you have this little gray area called what is asymptomatic. So if it's 100.4, we think that you're missing probably 80% of symptomatic people down to 99.5. And that is a very important matter of definition. So it's semantic. So it depends on where you set that number as to whether the person is asymptomatic. And so that's why we are pushing hard on raising the standard, which means lowering that temperature number.
Okay, we've got a couple other questions coming in. One is, and Rick, this may be for you, it could be for both. What do you recommend if you have visitors at a facility who scan hot?
Well, I mean, several of our customers say goodbye. They say, we hope you will return when you recover. I think people are very understanding. We've had and heard about incidents in the NICU. You have a mother who may be not feeling so sick, but scanning in high. So there becomes a question, and they will do further work on that. But for the most part, it's really a point at why take the risk is what our customers tell us. In cases where somebody is driving somebody to an outpatient surgical center where we have it, they may be asked not to be in the waiting room, and when they go and pick them up, as you must be there during the outpatient surgery in a lot of cases.
Great.
Let me weigh in as well, Steve. There's not a one-size-fits-all answer to that question. It really depends on the setting and exactly what you're trying to screen for. For example, if you're a workplace, like where we did our study in Mississippi, where the screening happens at the punch clock to make sure that anyone who's sick does not come in and infect coworkers. So when you get a positive there, I think unwellness was your term, then a signal went to HR, who came out to the check-in area and did a further evaluation of that person before allowing them into work. And examples of the evaluation questions were, do you have any other symptoms? How do you feel today? Anything unusual about how you feel? Do you have any sick kids at home? The kinds of questions without doing anything invasive, even so much as an oral thermometer, just to see the likelihood that there's actually an infection. Also, if there's suspicion, to take an oral thermometer, since the Wello was screening, not diagnostic, take an oral thermometer and see if they confirm a positive. If it's positive, then it's a matter of how well does the person feel and how likely are they able to conduct their job. They don't have to necessarily be sent home. They might be, put a mask on them and put them in a part of the operation where they're not around other people. In this case, it was a laundry facility that had a dirty side and a clean side. So any such worker would go over to the dirty side. And in the meantime, the HR policies were changed so that anyone who screened positive wouldn't lose time. They might be sent home, but they'd be able to make up time on another shift. So that allowed people to not try to sneak in and beat the system. So they really did effectively keep sick people out. So I just want to give that as an example of tailoring the specific follow-up to the specific circumstances.
We still got questions coming in, which are really good. Rick, I know you're going to smile when I read this one, but here's the question. Can Wello scanning be added to all airports and the airport screening apparatus to detect potential carriers from abroad when they land in the U.S.?
Yes.
I figured you'd like that, Rick.
It's very simple. You could put it in the food court. You could put 2 or 3 of them, and people simply, we dispense their sticker. They put it on their travel document. They put it on their jacket, and they can board the next flight or go through customs satisfactorily.
Okay, and we do have a question. We have a question that Chris is going to answer, and then I've got another question after that. But go ahead, Chris, the question you just got.
Yeah, we were asked if when people can play back the webinar and acquire the PowerPoint. We will email out the PDF version of the PowerPoint to all people who registered, and I'll send out the link of this recording of this webinar to everyone who registered tomorrow.
Another question we got, which is a really good question, is how do we deal with lowering the fever threshold if that also is going to produce potentially a ramp up of false positives? People with a little higher fever, say 100 degrees, but otherwise you're healthy and don't have a virus and certainly don't have the flu. How do you deal with the false positives?
Well, we're an evidence-based company, and so our database is well over 1 million scans, and we can tell you the amount of people that would be deterred between 99.1 and 99.5 or 99.1 to 100.4. We could tell you what that number is. And we're talking about 1 in 2,000 during a high season. We're talking about 1 in 6 or 7,000 during low, and it will not, during say the summer when there's less of an outbreak. So the answer to the question is it's fairly minimal. I don't want to say insignificant, but it is the difference between letting somebody through who is actually sick, called a false negative, as opposed to inconveniencing 1 out of 10 of those just to be able to get another measurement from them, or just get a survey answered, maybe take their name and number for contact tracing in the future. That's all.
Great. Well, at this point, we have no further questions pending, but these questions have been excellent. The people on this webinar have really asked some very great questions. And to reiterate, Chris is going to send the link out where you can play back the webinar. Andy's going to send out the PowerPoint. But I will turn it back over to Dr. Cohen and Rick for any final closing comments. But we want to thank everyone involved, especially Dr. Cohen and Rick, for this very enlightening webinar.
Well, again, I just want to thank Steve and the council for sponsoring this program and giving us the chance to share our experience. Thank everyone who participated for taking time out of their busy schedules to listen and, of course, to ask these excellent questions. And I want to go back and underline one point that I raised in my slides that I said was, to me, a very important point, and that is COVID-19 is the real deal. Don't underestimate what it means or what it's going to mean in the United States. We need to prepare, and hospitals need to seriously prepare as they would for, as we did for anthrax and Ebola.
Well, I want to thank you very much. This is Rick Heller. I wish you to be well. Please check out our website, Wello Inc., WELLOINC.com. We have blogs. We have a great deal of information on there, just beyond the products that we provide. Thank you again.
Thank you. And this will conclude the webinar, but we appreciate all the people that participated, and we certainly hope you have a great rest of the afternoon.